Let me move everybody so I can see you all, maybe. There we go. Okay. So today I thought we would talk about the assessment of violent ideation. Violent thoughts, other ways to say this are homicidal ideation. You'll see it in my, maybe. Okay. That my goal for today's presentation was is kind of twofold. I thought that this would be a good topic for us to talk about because we spend a lot of time, I know in my training experience, whether I'm working with graduate students or psychiatry residents and fellows and psychology interns, we focus a lot of time on teaching them how to assess for suicidal ideation. And that's very important. And it's a topic that we definitely need them to understand and feel confident in assessing. But I feel like a kind of similar area is homicidal ideation and violent ideation. And I don't feel like we spend the same amount of time when teaching about this area. And I mean, kind of specifically, how do you ask? Do you say, are you feeling homicidal today? Probably not the best way to question somebody who's having some of these thoughts. And so I thought that it might be helpful for all of the clinicians in the room to talk a little bit more about how do we assess violent thoughts in children, adolescents, and adults. And so my goal is that this will help kind of increase clinicians' confidence in assessing homicidal and violent ideation, as well as threats of violence. So we're going to do that a couple of ways. We're going to talk about first defining the different types of risk assessments, because there's quite a big difference between, seeing something that comes into your clinical practice, seeing something that's a threat in a school versus a forensic evaluation, such as I do often. And then I'd like to provide some information and some areas of focus for the assessment of risk in children, adolescents, and adults. And so this is providing you with possible questions to ask, areas to focus on, risk assessments to think about, so that you can feel more confident in when you're having to assess those individuals in the moment. And the tool that I'm going to use comes from this paper. I've got the citation here, and I can give everybody a copy. I can get it to Kelly, and she'll add it to the summary of this session. But it's called A Novel Approach to Assess Violent and Homicidal Ideation. The I Have It is the name of their measure. And so there's actually kind of goes through the measure, but doesn't just give us the full measure, unfortunately. But the kind of caveat to today's presentation is that it's not meant to give any clinician a crystal ball. None of us have a crystal ball to know with certainty whether or not somebody will become violent in the future. We don't predict future very well. What we're going to talk about today is that rather than predicting risk, we can manage risk, and we can use risk factors and clinical interviews to help guide ways to lower the likelihood that somebody engages in a violent behavior. But we're not great at just saying, yeah, there's a 35% chance that Mr. Doe will hurt somebody in the next 3 to 6 months. So let's start with some definitions so that we're all kind of on the same page in this conversation. So the first definition is violence. What do we mean by violence or violent ideation? So violence is the actual, attempted, or threatened physical or sexual harm of another person that is deliberate and non-consenting. Kind of makes sense. Again, keeping in mind here, we're talking about actual, so they engaged in violence, or they attempted to engage in violence, or they even threatened to engage in violence. All of that counts under this definition of violent behavior. And when we talk about a threat, we're saying we're defining that as the expression of intent to do harm or act out violently against someone or something. So using those definitions, let's talk about the types of assessments that can exist. And so I think I'm going to go a little bit out of order here. But the top one here talks about risk assessment. As a forensic psychologist, when I think about risk assessment, I'm actually thinking about estimating or or mitigating, attempting to limit the likelihood that an undesirable event will occur. This often means limiting the likelihood of reoccurrence of violence. Oftentimes when we talk about a violence risk assessment, or in West Virginia Code, a dangerousness risk assessment, we're talking about a person who has engaged in violent behavior in the past, and the courts or the treatment team wants to know what is the likelihood that it's going to reoccur. And maybe even outside of likelihood, how can we lower the chances that violence reoccurs for this individual? And that's where the management comes in. So it's not just about assessing. It's not just about predicting. It's about managing. And managing is the process of taking action to gain or maintain control of a situation. In violence risk, this means mitigating. Mitigating meaning lowering the risk through prevention, which includes early intervention and responses to any future violence. And this is contrasted a little bit with threat assessment. You may have heard the term threat assessment used to talk about really a lot of school issues, school shootings. They talk about whether was a threat assessment, did a threat assessment occur? And so a threat assessment is the process of evaluating an individual who has come to the attention due to disclosure or concerning behavior that might be suggestive of violent intent. The hard part with threat assessment is that no violence has occurred. It's stopping it before it happens, which I actually think is a little bit kind of more difficult and scarier to do than a risk assessment. These are the risk assessment I have kind of a baseline level of what behaviors a person has engaged in the past. And so the kind of the classic classic phrase, the best predictor of future behavior is what?
Past behavior.
There we go. Nick better get that behavioral training. Teresa, I saw you pointing back there. Yes, so best predictor of future behavior is past behavior. So in a risk assessment, that makes sense. I can predict or I can talk about the likelihood of future violence by looking at what their past violence looked like. In threat assessment, that violence hasn't occurred, and we're having to use a clinical interview and other sorts of information, collateral documents, to try to evaluate the likelihood that a threat is going to occur, and then how do I lower that risk? What do we do? So we're going to start with risk assessments, talk briefly about risk management, briefly about what a threat assessment looks like, and then we'll get into that tool that can be used in clinical practice to help us evaluate kind of imminent, violent threats and ideation. So let's start with just a few kind of general findings, general understanding we have about the risk of violence. And one of the biggest predictors that has come out outside of the best predictor of future behavior is past behavior, is this idea that what significantly predicts future violent behavior is the co-occurrence of three factors. And that's a person with severe mental illness, a substance use disorder, and a history of violence. So when you've got those three together commingling, that's a significant predictor of violent behavior. And to me, that makes sense because most of the people in my forensic world and the court system that I'm dealing with have the co-occurrence of all three of those areas. And these are risk factors that can help identify individuals who need to undergo a more formal violence risk assessment. And so again, just to give you an idea of the co-occurrence and why that becomes problematic is this idea that substance use plus a major mental illness, schizophrenia, bipolar, major depression, obsessive compulsive disorder, panic disorder, equals the highest predictor of violence. And you can see they did it by diagnosis, the percent of people who were violent in the past year based on diagnosis. Other drug dependence, 35%. If we're adding all of the three boxes at the bottom, if you put drug and alcohol use together, you're getting a huge percentage of the population. You're looking at this is why they say that substance is a huge risk factor. But if we take substance use disorders and we add in all of those major mental illness, we're hitting all but 2% of the population that was violent in the past year. Some more thoughts on that severe mental illness. When I'm thinking of severe mental illness, I'm often thinking of psychotic disorders and other breaks with reality. And so research tells us that within the first psychotic episode, 34% of patients will commit some act of violence before they get treatment for that severe mental illness. And what we know is that the positive symptoms of psychosis increase the risk of serious violence, and negative symptoms decrease the risk of serious violence. So just as a reminder of schizophrenia and psychotic disorders, when we're talking about positive symptoms, we're talking about symptoms that are not usually present in a person without a mental illness. So positive symptoms of schizophrenia include things like auditory, visual, tactile hallucinations, delusional beliefs. And so as they noted here, positive symptoms such as persecutory thoughts or paranoia in the context of delusions increases a person's risk of serious violence. However, negative symptoms of a thought disorder, so negative symptoms are those that are the lack of symptoms that people often exhibit who don't have a severe mental illness. So with negative symptoms, you're thinking social withdrawal, apathy, they don't really want to engage in any behavior, anhedonia, maybe restricted affect, they don't have a lot of emotional expression. Those are all negative symptoms. And so the more negative symptoms a person has, the less likely they're at risk for serious violence, mostly because these are individuals who are kind of withdrawing in amongst themselves and they're not out engaging in other people, increasing their risk of serious violence. And one to keep in mind when we're talking about severe mental illness is quickly growing paranoid fear, particularly if the person is fearing for their own life or safety. And so what happens sometimes when a person has kind of quickly growing paranoid fear is that they get this preoccupation with their life or concerns about their safety, and they get an energy burst. And so delusions that are suspicious or persecutory in nature are highly associated with violence. So it's not just delusions in general, it's a specific type of paranoid delusion, persecutory delusion. Someone's out to harm me or my loved ones, and I need to act on that belief. Those are the individuals at higher risk. So unfortunately, sometimes you'll hear people equating severe mental illness and violent behavior. And I want to make sure that we note here today that individuals with severe mental illness are much more likely to be victims of violent behavior than they are to be perpetrators of violent behavior. However, if we look at that kind of smaller grouping of people with severe mental illness who are at risk for violent behavior, these are the symptoms that are going to increase or decrease that risk of likelihood. So again, we're talking about a small proportion of the population with severe mental illness here. And in general, people with thought disorders are more likely to be victims than they are to be offenders of violence. But offenders of violence tends to be my area of work, and so that's what we're going to talk about today. Oh, I'm just going to move you all down to the bottom of my screen here. Please, everyone, I don't think we have a case today, so stop me if you have questions or if you have a case that you did want to talk about that kind of fits with our discussion today, or you have a question about something, please don't let me talk at you for an hour. I want you to take a look here at this picture. This is talking about risk, and it's talking about that to mitigate and lower and understand a person's risk is multifaceted. It isn't just they have this thought, they have a homicidal thought, therefore they're at high risk. But rather we have to look at a variety of different areas. The first is, what is the nature of the thought? Is the thought that I want to slice the tires of a partner's car? Or is it I want to kill a partner? So what is the nature of the violence? Is it to hit someone or is it to attack them with a weapon? And so as the seriousness of the violence goes up, their risk gets into orange and yellow and less in the green. But then we also need to look at what is the likelihood. So in my training, I did some work at the Federal Bureau of Prisons, and we were doing risk assessments on individuals who had engaged in federal crimes. And one of the federal crimes that we would see with individuals with mental illness was threats on the life of the president or other high-profile government officials. And so I bring that up because we'd have to look at the likelihood that somebody could engage in this behavior. So when the Secret Service has a tip that somebody has threatened the life of a significant government official, they're looking at one of the things they're looking at is likelihood. So that's kind of like what means does this person have to engage in this behavior? How likely is it that they're actually going to be able to cause the harm that they say that they're going to cause against an individual? Uh, Tara, did you have a question? I see your hand up.
Yeah, so actually, I saw an individual yesterday that this kind of applies to, and I wasn't sure how to go about with it. I do like safeties, the suicide risk assessments through Ruby and on Fairmont Floor via telehealth. And I saw an individual yesterday denied anything to do with SI, and at the end of our like meeting and me talking with him, he mentioned like he had thoughts and a plan to essentially shoot up a government building, like the court and everything, because they wronged him. However, he didn't have access to guns immediately. He said he would go dig up his arsenal from his backyard.
Oh, geez. Yeah. So interesting. If we look at, can we talk about, Tara, do you mind using your case to go through these different areas of risk?
Yeah, that works with me. Yeah.
Okay. So if we look at severity, he wants to shoot up a government building. I'd say we're probably getting up to a 5 here, right? Like that gets to be quite severe. But then you talk about the means, like at the moment that you were assessing this person, did they have access to lethal weapons to shoot up a building?
No, he did not.
And were they able to leave wherever they were located and get to a government building?
Um, he could have. However, I placed him at like a moderate risk, so they had to consult psychiatry before he could even leave.
Okay. But so at the moment you were talking to him, he was kind of secure in the sense of like you could have called people that made sure he didn't leave the building it
Yes.
was located in, even if it was law enforcement, different means of doing so. So where would you put the likelihood that he at this moment could have uh, completed his plan?
It was a very low likelihood.
So what do you think? Two, three?
Probably about a 2.
And I wish I could show you my like pencil screen, but if we go up from a 2 to your 5 severity, right, or a 2.5, even all the way straight up to the 5, you see we're getting to red, like we're in the orange range here. Even though we don't think it's that likely he could engage in it, the plan itself was so significant and severe that we're definitely going to take it seriously and kind of make the next steps. So we know the nature of the plan, right? He wants to take it sounds like a gun to a government building, shoot them up. The likelihood we say is kind of low at the current moment because we have safety in place. What is the frequency of these thoughts for him?
He's been having these thoughts for many years. It has to do with garnishing of wages and whatnot. So it's almost like chronic.
Okay. So this is a chronic thought. This is not like this thought came into my head today and I might do it. This is something he's been kind of prepping and planning. So frequency can be like how often during a day is a person thinking about this behavior, can be how long over a period of time. Is this planned? We talked about severity and seriousness, I'd say are the same thing. So we've talked about that. In this case, it was pretty high severity. Then we're looking at imminence. And so this kind of goes back to likelihood. Likelihood can be like, could they ever put this plan together? Like, yes, this person likely in the state of West Virginia could get a weapon. He knows where the government building is. He could access it. So in theory, like the plan is reasonable in the sense of like, this isn't that he would have to make this really special bomb that would take an expert to help him and ordering things offline from different places across the country. Like these are things that he actually could have access to. But the question is, what is the imminence of the risk? How likely is it to happen right now? Or is this something that we should worry about happening in the future? And so I think, Tara, your question being asked of you in that moment was, right now, is this imminent? And so, or what can we do to reduce the imminence? And so I think sometimes when we think about the imminence, we think about, when you're doing safety evaluations for suicide is, well, one way I can reduce imminence is by placing them in a secure environment where they can't leave and they don't have access to ways to harm themselves. The same way with homicidal ideation or violent ideation. What safeguards can I put into place that keeps it from being an imminent threat? And the last is the context. And so the one example that I think about with this, Tara, did this person have any physical disabilities?
Yes, he did. That's why he was in the hospital.
Okay. So was he physically able to walk into a courthouse?
It's unlikely, yes.
Okay. I bring this up because one example I always have is, say a person is a quadriplegic. And so maybe they've been very violent in the past and they have very violent ideation, but physically now they're limited in such a way that they can't physically engage in the behavior that they're threatening. Now, could they get other people to do it for them? Possibly, but they can't themselves do it. Another way to think about context is maybe this person wanted to shoot up a courthouse in California, but they were on a no-fly list and they have no income, they have no money, they have no way to get themselves to the state of California. And so that's where we bring in context. Like there may be reasons that somebody isn't at imminent, we don't deem them to be at imminent risk because we're taking these safeguards. Another one to think about though is what if we do a risk assessment and this person has no risk factors? We have no concerns. We think, yeah, his historical factors tell us this person is not going to be a risk of violence in the future, but they tell you, on my way home today, I'm going to shoot the first police officer that I see. Well, that would change the context, right? That would tell us, okay, I don't care if their risk factors tell me this person's not a risk. Their behavior and what they're stating right now is telling me they are. And so I hope that makes a little bit of sense, Tara. I really appreciate your example because I think that helped illuminate some of these ways that we have to think about risk and how it's not just like the person made this statement and therefore I should jump to all of these conclusions because of it. It's also reminds me that, this is where I was saying we do a really good job teaching how to assess suicide, but it gets much murkier when we're talking about homicidal risk. So I want to talk about different types of risk factors. We're really going to focus today on two types of risk factors, static and dynamic. Static risk factors are those that are unchangeable. They don't change over the time. They can't be changed with intervention. So they're things like a person's age, their sex, their social class. Maybe social class could shift over a period of time with education and jobs. I like to think of static risk factors are things that don't get better over time, but they can get much worse. So you can think about a person adding risk factors to themselves over time, but they're never going to go away. Because once a person has a history of violence, they get that check marks for violence. Once they have a history of abuse, they get the check mark for abuse. Once they have a history of a substance use disorder, they're going to check that box for risk of a substance abuse disorder. So these aren't things that necessarily get better. They're just kind of facts or things that are pretty stable. As opposed to dynamic risk factors. Dynamic risk factors are those that can be changed by intervention or possibly changed by intervention. And they kind of help us predict that short-term predictor of violence. And so, such as Tara's example, where she's got to make a decision about a person who's in the hospital right now, and what's the likelihood this person is violent in the very imminent future. We're looking at a lot of dynamic risk factors. We're considering the static, but the dynamic are the ones that we might be able to modify or change. So and they talk about different types of dynamics. So they talk about acute. So these are ones that rapidly increase risk but can change rapidly. So if somebody is currently intoxicated, their risk of violence increases because alcohol is going to disinhibit them. However, if they stop drinking or stop using the drug, that risk rapidly decreases again. So if we keep them in a hospital with no access to drugs or alcohol, that risk could rapidly decrease. Irritability, that is something that could rapidly increase a person's risk of imminent violence, but can also change pretty quickly. Emotion dysregulation the same way. There's other dynamic risk factors that are more stable. They take longer to treat. Not that they can't be treated, but they're going to take a longer time. Things like the person's living situation. Are they homeless? Do they have a home? Are they in fear of becoming homeless? Access to weapons might be something that can change. How about severe mental illness symptoms? It takes a bit to change psychotic symptoms, even with medication. It's not going to be in the next hour, their symptoms are gone. And then kind of a feeling of loneliness and isolation and lack of alliance with other people, that's going to take a longer period of time. There's talk about like a tendency to approach situations with aggression. Another way this gets talked about is there may be like a ambiguous situation that maybe the average person not prone to aggression would look at it and be like, I'm really annoyed. But when a person is prone to aggression, they jump straight to violence. Thinking about the traffic, Morgantown's about to explode with students coming back. Traffic's already starting to get heavier than it was all summer. Different people are cutting each other off in the cars. A person with a tendency to approach frustration with aggression might really get violent in a road rage situation where another person might get frustrated in the moment and then let it go quickly. Other things we're looking at are like recent violent behavior. That's dynamic because that could change over time. Being a recent victim of violence, substance use disorders I talk about here. The other one that I think about is one of the most risky times for an individual in terms of usually suicide is actually being placed in jail or changes in financial status. So if people lose a ton of money, say the stock market crashes, sometimes there's an increased risk in people completing suicide. Some other general risk factors for violence towards others: substance abuse, including withdrawal from substances, the availability of lethal weapons. I think the statistic that I always state is that 92% of people in the state of West Virginia own a firearm. And so when you're assessing for suicide risk and even homicide risk, it's not usually a question of, do you have a firearm? It's what firearm, or, where's your firearm? How is it stored? Could we do anything else with it? And then there's other lethal means. Most people have access to a knife or kitchen knife that could cause significant harm to people. Another risk is the self-report that they're likely to hurt someone. I mean, if somebody tells you, I'm going to hurt so-and-so, we usually are going to believe them, right? Past violent acts. One thing that you can ask is, what is the most violent thing you've ever done? If there is an identifiable person who has been threatened, and so in the case of the individual Tara was assessing, if he had said, I'm going to the courthouse and I'm going to attack this specific judge, that increases it because it kind of leads to the idea of increased planning, and that there's kind of like there's a motive to do it, right? It's to get back or get revenge against someone. People who have poor control of anger, employment status, people losing their jobs. This one talked about garnishing of wages. When you mess with people's money, definitely increases the likelihood of bad outcomes. And below average intellectual functioning they talk about here. I think this is more that, people with lower levels of functioning may have poor coping skills and may be more impulsive. They might not deal with emotion regulation very well. They may not have as much they may not have as many skills in problem solving, and that tends to lead to risks of violence, not just simply the fact that a person is lower in intellect. That's violence risk. let's talk about threat assessment. Let's talk about that before the violent incident happens. What is done? Oftentimes now, what the research tells us is that threat assessment should be done with teams. And so it's not one person making a decision, it's a multidisciplinary team of people that are coming together to make a decision about the seriousness and the imminence of a threat that's been made. And so effective threat assessments evaluate the presented facts of the case and the context of the threat. They don't just focus on the characteristics or traits of the individual. If we look at the awful school shootings that have happened, if we look back to Columbine, what is the one thing that sticks out? What sticks out to me is that they still talk about Eric and Dylan and wearing their black trench coats and their love of, really dark music. And the media focuses on the characteristics or the traits of the individual. That is less helpful when we just say, and this is where people get upset, right? Oh, if you play violent video games and you wear a trench coat and you like violent music, then you're going to be a school shooter. We know that that's not true. We know that there's not this profile we can just check boxes for. What we have to evaluate is the facts and the context, in addition to some risk factors of the individual. And so areas that are assessed in threat assessments include what is the motive and who is the target selection. And we're going to talk about some of these with specific examples of questions that you can ask when we're talking about imminent threats of violence. They talk about what is the level of severity of the violence that they're considering or planning or have threatened. What is the intensity of the preoccupation? This sometimes comes out in things like letters or social media posts or searches in social media or diary entries or drawings and art. It kind of looks at how often are they thinking about this or thinking about violence in general. Disclosures. Threat assessment teams often talk about this idea of leakage, which I think is a terribly sounding word, but it's the idea that most school shooters, most violence, school violence doesn't occur without some leakage or some information, or someone said something to someone that they heard they may have threatened this behavior, or, well, I did see he posted on Facebook about being mad at so-and-so. And so it's these little pieces of information that have leaked out over time that if we had noticed them and kind of combined them together as red flags, could have given us some ideas that this was happening. We want to assess their accessibility to weapons. We want to assess these risk factors. We want to look at recent behaviors and past behaviors. We want to look at their stress response. How do they react in different times of stress? And what are their coping abilities? Some more areas. Oh, did we have a chat message? Oh, some other areas of emphasis in threat assessments are ability, when we talked about some of this, and when we talked about kind of risk assessments, but ability. What is their capacity to act out this plan? Do they have access to the means to act out their plan? What is their intent? How intense is their beliefs? How intense are their preparations? And what thresholds has this individual crossed? This could be previous violent behavior, could be other wrongdoings. This could be like planning or like, I'm missing the word now. This could be ways in which they've like practiced for pieces or parts of the event. Looking at the degree of concern of others. If people around this individual are very concerned and very scared, that's important to keep in mind. And has the person been non-compliant with treatment strategies in the past? Oops. Okay, so kind of have an overview of threat assessment and risk assessments. And now we're going to look at imminent risk along the lines of what Tara was talking about having to do yesterday in the assessment of violent ideation. Again, this comes from that I Have It tool and I'll send you the paper that they wrote about it. Actually, it's nicely set and easy to kind of understand there. But the I Have It tool is going to look at violent ideation assessment in 3 areas. They first want to look at the current episode. Then they do a review of risk factors. Then they do a mental status exam on the person. And then they do the overall assessment. They kind of put it all together. So we're going to go through each one of these. So first, they talk about the current episode. And so this starts for them with like the patient complaint. What are they coming in for? Why are we seeing this individual? What have they said? What is their report for why they're presenting to us? And also, this is where you get parent or third party report. So you might get the person's report and the parent's report and somebody else who heard's report, and they don't match. And you're kind of piecing together where lies the truth. The next thing that they recommend doing is to identify the target. And there's some examples of ways you can identify the target are asking them, is there a specific person or people that you want to harm? Who are they? What is their name? Do you know where they live or how to find them? Do they know that you want to hurt them? Have you hurt them or threatened to hurt them in the past? These are all examples of questions you could ask. After kind of identifying that target, they suggest that you look at the method in which the person wants to engage in that violent behavior. The goal here is to determine whether it's realistic and whether they have the access to the means to do so. So how do you want to harm or hurt this person? What would you do? What would you use? Where would you do it? Do you have an access to guns or other weapons? Which, how? The next step is to look at the details of the plan that the person has. The steps or actions that they've thought about taking or have already taken to prepare to carry out this violent act. What is your plan? How have you prepared for it? Have you gathered items? Maybe ask them, have you searched online? Have you rehearsed this mentally? Have you written it in a journal? Have you put comments on social media, made hit lists? How often do you think about, imagine, or make plans for violence? Once getting the details of the plan, they suggest looking then into intent. This looks at how much this person wishes to engage in the behavior, but can also look at the acute stressors. So you're looking at whether the person would actually do the harm to the, sorry, that should be target, the targets at the moment, provided the opportunity and availability. So would they actually conduct this violent act if they provide the opportunity and the availability of the target? So when or under what circumstances would you carry out these thoughts and or your plans? How likely is it if you weren't here right now, weren't here right now in the clinical setting, that you would do it? And then again, and then after looking at the intent, we look at, okay, so now we know how likely it is that they would actually engage in this behavior. So what could stop them from engaging in this behavior? And so these are important areas to target for mitigation or lowering the risk and treatment planning. So ask them, who might be upset if you hurt somebody else? Is there any reason why you would not carry out these thoughts or plans? Kind of playing off the, well, my mom would be devastated if I hurt somebody else. And it kind of gets at that empathy and perspective taking and whether or not they have those skills as well. So again, we talked about this a little bit, but that leakage is the ways in which individuals intentionally or unintentionally reveal feelings, thoughts, fantasies, attitudes, or intentions regarding violent acts to a third party. And they often find that in every one of these school shootings, there has been some leakage that either people didn't take seriously, or if they did take it seriously, it somehow got lost in translation or not answered appropriately. These could be direct spoken threats or boasts. It could be drawings, diary entries, written material, videos, or internet postings. One of the questions that can be asked in your assessment is, who else have you told? Have you talked about your plan on social media? So once we kind of get that, kind of like understand the function of that, of the thought and the threat and the behavior, then we look at the risk factors. And so this I have it checklist, actually, I have it tool has a checklist for dynamic risk factors and a checklist for static risk factors. And they also then talk about protective. So this is probably hard for you to read, but we can, we'll get you these slides so you can keep it with you. And so of note is it gives you kind of citations of some of the studies that demonstrate these. And so you'll find these in that paper. The bolded items are the best predictors of violent behavior, the strongest predictors of violent behavior. But you can think of it like a checkbox. So if we use Tara's into person as an example, is that okay, Tara? Okay, so can you help me kind of checkbox this out? It sounds like the person was male,
Yes.
right? Had they previously they've had these thoughts for a long time. So they previously had ideas and intents and plans, right?
Hmm.
So they're checking there. Any previous suicidal thoughts or attempts?
Yes, I believe so.
Okay. Um, and you may not know some of this information, but what age did they begin having the violent thoughts and behaviors?
It's gonna probably be between 20s and 30s
Okay.
because that's when the event occurred.
So not an early onset. I mean, we're talking like young children, 10, 11, 12 for early onset behavior. Do they have a criminal history? Have they ever been arrested? Juvenile
No.
detention? Never been arrested. Do they have any physical abuse in their
Uh,
past?
they have a military history, so that's kind of unknown.
Okay, possibly. How about any other, we have no criminal history, so no other violent transgressions against people or property. In most of the risk assessment literature, we do not consider work sanctioned or publicly sanctioned violent behaviors. So any killing or harming of people done in the military does not count as violence. In the same way that a surgeon cutting a person open for surgery is not considered violent. Appropriate use of force with police officers is also not considered violence. But it is something to keep in mind of like they have access to weapons, they know how to use weapons, they have kind of that, if you look back at the suicide literature, this acquired ability to harm that can kind of raise some concerns. Victim of sexual abuse.
Kind of unknown. We don't have any of his previous records for any of that information.
Some of these are hard. Any parenting, anything about their family history?
He did not say anything in regards to his parents or anything. And all he told me, like with him being a parent, his child was taken from him.
Okay. How about socioeconomic status? Is it low?
He is experiencing some hardships right now. He recently moved from a different state here.
And then again, you probably don't know this one, but we'd ask, about witnessing domestic violence. Any, was in the military, so probably not an intellectual or learning disability, but it's always worth assessing, or getting records for any changes in academic functioning. Again, because this measure can be used with children, adolescents, or adults. You're kind of looking at that academic decline. Any history of impulsivity that you know of?
Not that I am aware of, no.
Okay. Now this is starting to get into that dark triad of, cruelty to animals, fire setting, and sexual violence. But any cruelty to animals?
No, he has a dog who he adores.
Well, any fire setting.
Not that I'm aware of.
Okay. Then they get into kind of attitudes and behavior, selfish, unemotional, callous, remorseless. You can imagine this is kind of like the psychopathic traits, or in kids, we talk about it as, oh gosh, callous and unemotional. Any of that with this one?
Um, Not that there's like record of or anything, and he was very pleasant
So
individual.
some risk factors, but he's really not that risky
Mm-mm.
on paper using just static, which is why just using a historical view of a person's behavior is not a great predictor of their current risk. Okay, so next we have dynamic risk factors. So this is more the stuff that's changeable, but that's kind of going on right now. So let's talk about that person, acute stressors.
Yes, he is experiencing issues with housing and recently moved from a different state to here.
Huge stressors. Military background, likely has access to weapons, especially guns, right?
He reported that he doesn't have any guns in his home. However, he did, quote unquote, say he could go dig up his arsenal from the yard.
Any substance abuse problems?
He has a small history of some substance use.
Okay. Acute major psychiatric issues.
Has some nothing too much other than possible anxiety and depression.
And so I might even say that's probably not a checkbox unless the depression was significantly impacting kind of the current thoughts and behaviors. How about treatment noncompliance?
He was compliant, and then he moved up here and he has not been reestablished.
So maybe it probably wouldn't even count that at this point. What about explosive episodes, past or recent?
None that we have record of.
Okay. Psychotic symptoms, paranoia, delusions, hallucinations.
Nope.
Okay. What about medical problems?
Um,
Any current withdrawal?
mm-mm,
Okay. Head injuries, epilepsy.
mm-mm.
Okay. Any deficits in social interaction and emotion regulation? Sounded like he was pleasant with you.
Yeah, he was very pleasant with me as well as the APP who also saw him.
What about cognitive rigidity? They have like set ways things have to be done. He can't be flexible in his thinking, very black and white.
Uh, that one's kind of on the fence, I think.
What about lack of interest or ability in making social connections? Was he alienated, meaning he wants to have friends but doesn't? Isolated, lacks friends, groups, mentors?
I would say he's isolated as of right now just because he did move to a new area.
About difficulty with cultural assimilation? Is he from a different culture?
No.
Negative relationship with religion or spirituality?
Um, no mention of religion or spirituality.
How about poor coping skills?
Um, I could, I would say maybe yes for that.
Okay. Bullying might not be one that you really got into, but again, if we're assessing children or adolescents, it's probably more relevant. Any gang involvement?
No, not that we're aware of.
And so that's one not as prevalent in West Virginia. It talks about internet violent group associations. And so that's where, you could get into some of the political extremists, like way 4chan and kind of some of that stuff can lead to problems. And then probably doesn't have limited educational resources. And then we probably don't know much about school commitment. So even in the dynamic risk factors, not a ton that are super concerning here. I think his current episode is that area where you would have hit all those things that concerned you a lot more than the risk factors, which is why it's important to kind of hit all three. So the last, let me talk about this double hit risk factors real quick, and then we'll hopefully get into mental status. Let me go through this quickly. So
We have 4 minutes, just so you know.
thank you. So these authors of this article we're talking about, a couple of combinations that together added to more of an increased risk of violence. And they said, so somebody on the autism spectrum who also exhibits callousness would be concerning. Schizophrenia plus substance abuse, that's the one I see a lot in forensics. Personality disorders and substance use, I see a lot of that one. And then cognitive rigidity and bullying. The authors then did a mental status examination. They wanted to focus on really differentiating whether a person had any psychotic symptoms, whether there were symptoms of autism spectrum disorder, and whether there were symptoms of conduct disorder. So they were looking more at, was this person lost touch with reality because of psychosis? Is there something going on, autism spectrum, neurodiversity, or is there like conduct disorder or psychopathology or psychopathy going on? And they did this with behavioral observations. They also asked really brief tests of social relatedness, theory of mind, and social sensitivity. They were noting this as a tool for children and adolescents, and they noted some research to suggest that autism spectrum disorders may, in combination with other risk factors, increase the likelihood of violence. So last, they end with an overall assessment. So they take that current episode section and they want you to note it as mild, moderate, or severe. Mild is like no problems. The threat, the thought is gone. Moderate is there, the threat is still there, but it's modifiable with treatment. And severe is like it is imminent, it's going to happen. We need to take, we need to manage it right now. So they do that for each of those 3 areas, and then they give an overall impression section.
Dr. Lillard, you had a question in the chat box from Sandy that said, curious about
I'm gonna
specificity and sensitivity for the IHAVAT.
Yeah, Sandy, I've got to pull up the paper. I will tell you that this was like the first test run. So they presented their model and then they gave one small study they did using it. And so I would say it is not like this well researched. They talked about needing some more data for the questions. And so it's probably does not necessarily have good specificity and sensitivity. It's probably gonna, but the kind of nice thing is that it's more of a clinical, structured clinical judgment measure. And so all it's helping really to do is help organize our brains as clinicians to consider the right areas, to make sure we're asking the right questions in the current episode, considering the right risk factors, looking at the mental status examination of the person right in front of us. And so rather than saying, yes, they're at risk or no, they're not, it's kind of just guiding us to still have to make that clinical judgment for ourselves. But yeah, that paper, when I send it to you, it will have some information about the specificity and sensitivity to it. I would guess that it's going to be more inclusive, that it's going to collect people who are actually not going to be violent, more so than it's going to leave people out. Other questions? Sorry for taking up all of our question time. If you guys have any further questions about this, please feel free to reach out.
All right, guys, our next session is going to be held on September 4th, and it will be on managing and prescribing for paranoia treatment by Dr. Swagger.